Dear friends, my name is Dr. Igor Atabekov. I am clinical oncologist practicing since 2010. Today we are going to discuss the topic of testicular cancer. It's the most common cancer in young male adults. And I will tell you about one of the patients that went into our clinic just yesterday. It's a very interesting case and we'll talk about the mistakes that were done in his situation. So let's start. So again, testicular cancer is the most common type of cancer in young adults, and the incidence is increasing in the past decades, maybe because of the food or the pollution, radioactive influence, or maybe even electromagnetic waves from many devices surrounding us, starting from the wires in the walls, from mobile phones, from microwave ovens. Even it's not proved to be cancerogenic, but still it is influencing our body for sure. For example, there are studies that show that if you use your phone often, if you call somebody, you are at increased risk of tumors in the brain near the ear. And also we know that electromagnetic waves influence very fast growing and dividing cells, like for example, sex cells. And many people, they carry their mobile phones in their pockets of their jeans. Again, it's not proved to be true, but theoretically it is highly likely. Good news, because of the improvement of their treatment in oncology, nowadays we have the 5-year survival in testicular cancer that is 97% and a very high cure rate in this man. What are the risk factors? Risk factors mean there is increased risk. It doesn't mean that absolutely for sure the person will have this cancer. Actually, this cancer is quite rare. Family history. If the father has or had testicular cancer, then the person has almost 4 times higher risk than the usual population. If the brother, it's 8.5 times higher risk. If the person has infertility, it's 2 times higher risk. If the person has cryptorchidism, it's when the testes don't descend to their scrotum after the baby is born. In the non-distended testicle, the risk is 6 times higher, and in the other testicle, which is normal, for example, it's still higher, but not very high. They do the manipulation, the surgery to descend the testis and fixate it in their scrotum, and if they do it early in life of the person, of the boy, then the risk is still increased, but not as much, only 2 times. But if they do it after puberty, it's almost 6 times higher. And also in AIDS patients, because of their decreased immunity, they may have increased risk of testicular cancer. But if they get their antiviral treatment, then their risks are not increased. That's why immunity is very important. And look, inguinal hernia, marijuana use, diet, smoking of the mother, high body weight, they are not risk factors for testicular cancer. What are the tumor types? For someone who thinks that, okay, cancer is all the same, why there is no cure for cancer? Because all the cancers, if on one testicular cancer, look how many types there are. And even one type, for example, seminoma, in different patients, they will look different, they will behave differently, and they will be have different sensitivity to our treatment. That's why there can be no panacea for all types of cancer. But oncology is improving and we get better and better treatment options for this type of cancer, for that, for the other one. But for some, we still are not very successful. Most of the testicular cancer are germ cell tumors, meaning that they develop from the germ cells or cells of the gonads. And the most prominent types are seminoma or non-seminoma. Here they're embryonal, yolk sac, trophoblastic, teratoma, and many of them are mixed, like in the patients that I will be talking about today. That's why the treatment and the prognosis will depend on the type of the tumor. Let's get further. What are the symptoms? First of all, it can be pain in the scrotum, or it can be just some painless mass. It can be heaviness or swelling of the scrotum. It can be gynecomastia, when you see the shape of their breasts in these males. This is because of the production of chorionic gonadotropin, the same hormone that is used for pregnancy test, and it is very important for pregnancy. And when the man does pregnancy test and, oh, I'm pregnant, and he's laughing, no, it's not funny. He needs to do investigations. Next, all the other things are already about the metastatic disease, and it depends on where the metastases are, what are the sizes. It can be headache, it can be back pain, it can be swelling in the neck if the lymph nodes are affected. It can be cough, shortness of breath, or blood in the sputum if the lungs are affected, or the metastasis may affect the belly and gastrointestinal tract. That's why the person must come to the doctor. He will examine him, he will ask about symptoms, he will see the lymph nodes, he will do ultrasound. But if you have any of these symptoms, it doesn't mean you have a testicular cancer. There are many other possibilities. For example, there can be inflammation of testicle or of epididymitis. It's a structure near the testicle, and it's usually in mature adults who lives the sexual life usually, and who can get some infection. Usually it's connected to pain, swelling, maybe redness, it can be fever, it can be some discharge. And antibacterial treatment may solve the problem. The other infections may be tuberculosis or syphilis. Also it can be hydrocele. This is accumulation of fluid between the membranes in the scrotum. This fluid can come from the belly if this connection is not obstructed. And if you see with the light, the scrotum will be full of liquid and it will be transparent, transluminating. Also it can be, for example, blood accumulation. It can be hernia, inguinal hernia, when the contents of the abdominal cavity go through the inguinal canal to the scrotum. And it looks like a mess there. Also it can be varicocele. This is the enlarged veins of the testicle. They look like a bag of worms, and the person, if he's standing or doing like, then they may enlarge. This thing is very common, and they really sometimes may need surgical correction if this problem is severe and if it causes the changes in the sperm test, because it can cause infertility. And by the way, hydrocele sometimes may also need to be corrected surgically if it's large and if it's compressing testicle. And by the way, it will be less in the morning, and when the person stands up and walks around, then it will be bigger because the liquid will go down and accumulate in scrotum. And one more is testicular torsion, when the testicle is torted around and the blood flow will be impaired, and it's a serious condition, very painful, usually sudden onset. It can be redness, swelling, and this patient might have the consultation of the doctor urgently because this condition is serious for his future fertility, and it must be corrected surgically, and the testicle must be fixed so it won't tort again, or at least if there is no surgery possibility, it must be twisted back into the normal position, which will remove the pain. But in future it must be fixed anyway. So, okay, these are differential, these are what we need to exclude. But then the doctor will do ultrasound, and if he sees any mass in the testicle, if he sees that it can be cancer, then this testicle must be removed. Before removing, the person must do blood tests, and he must do oncomarkers and hormones like beta HCG and AFP that may increase in many testicular tumors. Why? We must know, because it's important for the prognosis in future and to decide which treatment to use in this case. And also, after treatment, we will recheck that and see if it goes down, if it normalizes. That means, okay, good, we removed this tumor that was producing that. And afterwards, during the surveillance of the person, we can monitor these things. If they start to grow up, for example, in 2 years after treatment, we'll be very suspicious. And LDH also, it shows the bulk of the tumor in the body. But unfortunately, as other oncomarkers, these things are not very accurate. They may be normal when there is a tumor, or they may be abnormal and high when there is no cancer at all. For example, AFP may be increased in liver cancer, in pancreatic cancer, in gastric cancer, in just cirrhosis, in trauma, in viral hepatitis. That's why it's not non-specific at all. But we have some newer markers like microRNA 371A3P. It's quite specific and accurate, and it's a novel marker for these tumors. Unfortunately, there are some tumors of the testicle, like teratoma, that won't produce it and it will be normal. But still, it's quite a promising indicator. Next, we need to check for metastasis. For that, we do CT, computer tomography of abdomen and pelvis and chest with intravenous contrast to see if there is any tumor spread. It's very important which treatment to choose in future. Sometimes MRI of the brain or CT or scan of the bones may be needed if we suspect any problems there. Next, the surgeon will remove the affected testicle. And if it's the first stage, usually we can do active surveillance if there are no risk factors. It's surveillance of the person doing investigations very often to monitor the patient if there is any relapse of the disease. And in some cases, there may be needed chemotherapy or radiation therapy or surgery to remove metastases. It depends on the individual situation. Prognosis. We see that seminoma of the first stage has an excellent prognosis. 99% of patients will live after 5 years after treatment. Second stage, if they do also chemotherapy and radiation or radiation therapy, also 99% will live, because this additional treatment will significantly decrease the risks of relapse of the disease. Next, if there is other type of testicular cancer called non-seminoma, then in stage 1 we can do also observation or surveillance. But if there is no risk factors in first stage, after 5 years, in 12% of patients, there will be relapse of the disease. But if there are risk factors, then it will be more than 1/3 of patients will have their relapse. What are the risk factors? First of all, after the removal of the testicle, it will be sent to the lab, so the doctor will see under microscope. And if there are some risky characteristics there, if the tumor is very invasive into surrounding tissues, it is the risk factor of recurrence. Also, if the tumor is more than 4 centimeters, or if it's embryonic tumor, then these are risky. Then these patients, even with stage 1, they may need chemotherapy, which will decrease the risks of relapse to only 3%. You see the difference, 10 times difference, more than 10 times difference. And stage 2 non-seminoma, after removal of the testicle, the person may need chemotherapy and or removal of lymph nodes, because testicular cancer often gives metastasis to lymph nodes in the belly. And if we do all the needed combined treatment, then the risk of recurrence in the first 5 years is only 3 to 4%. So these results are quite impressive. Now, about the patient. 37-year-old patient, young man, came to our clinic, and 2 years ago he had the removal of the one testicle because of testicular cancer. And at that time he had metastases in his belly. They were small. And he refused to get any treatment, refused chemotherapy or radiation therapy, and that time it could heal him, but he refused. And in half a year he started to feel some symptoms. He went to the doctor, they did investigations. They saw that he got the enlargement of these metastases in his belly. He had two chemotherapy courses, and they normalized his AFP and HCG. I was talking about them before, but the tumor, the metastasis continued to grow. Why? His tumor was mixed. The chemotherapy killed one part of the tumor, which was producing these hormones. But the other part of tumor was not sensitive to this chemotherapy, and it can happen really, and it continued to grow afterwards. He got other chemotherapy, and it didn't help him. The tumor grew further. They took biopsy, it was the metastasis, and you can see the large tumor. It is compressing guts, it is compressing important big blood vessels in his belly that supply with blood the lower part of the body. He has problems with his legs, he has numbness, he has pain, and now we are considering the surgical removing of this metastasis and trying the other line of chemotherapy. By the way, in this type of cancer, even 2 first lines didn't help him. There is still chance that the next line will help him, and even all the tumor in his case may disappear. So we will hope for the best. And if you're interested in what will happen to this man, what will happen in future, please write the comments below, and with the course of time maybe I will make a video about him, or maybe I will just write his story in the description. We will see. I still don't know what will happen during surgery and what will happen during his chemotherapy. Will this tumor be sensitive to the other line of chemotherapy? And why we don't want always to give the patient chemotherapy and radiation therapy? Because it can have some consequences, like secondary leukemia, radiation therapy to abdomen, to belly, or to the pelvis may increase the risk 3 times. Also, there may be other tumors and cancers, like if radiation therapy was done, it's 2-fold increase, if chemotherapy 1.8, and both almost 3 times increased risk. What types of tumors? Stomach, pancreas, pleura, bladder, colorectal, esophagus, melanoma, thyroid, kidney, and sarcomas. Usually these risks start to occur after 5 years. Next, decreased fertility. Of course, if the patient has chemotherapy, it will affect their fast dividing cells like sex cells, but 50% of patients, even before any treatment, they already have some problems with fertility. I told you before that infertility is the risk factor for testicular cancer. But unfortunately, up to 90% of these patients after successful treatment will have kids with using or without using the fertility assistance, like in vitro fertilization, for example, or sperm banking. Also, decrease in sex hormones may occur. Sometimes they may need testosterone, and there are increased risks of atherosclerosis and cardiovascular risks starting in approximately 10 years after treatment. That's why, when it's possible, oncologists try not to use chemo or radiation therapy. Anyway, it doesn't mean that these patients will have anything of that. It's just increased risks. Small conclusions. Testicular cancer has a good cure rate nowadays. Risk factors are personal history or history in the family or non-distended testicles. The main method of examination, except for checking the body and checking lymph nodes, is ultrasound. A symptomatic general population doesn't need any investigations if there are no risk factors or symptoms. And after treatment, follow-up by oncologist is required to see if there is any relapse, and the earlier we can detect it, the better the prognosis and the treatment effectiveness will be. And after chemo and radiation therapy, there are increased risks of some secondary tumors, infertility, or cardiovascular disease. Dear friends, my name is Dr. Igor. I hope it was interesting for you. I wish you good luck, good health, God bless you. See you in the next videos. Bye bye.